My presentation covers the topic of congestive heart failure. Many of the patients that I treated and worked with during my clinical rotation were suffering from some form of CHF. MA is a 65-year-old male admitted with CHF exacerbation and fluid overload. He has a past medical history of coronary artery disease, hypertension, hyperlipidemia, type 2 diabetes mellitus, chronic kidney disease, obstructive sleep apnea, and obesity. Congestive heart failure is present in 2% of people ages 40 to 59 and 5% of people ages 60 to 69. It is the most common diagnosis in hospital patients aged 65 years and older. Congestive heart failure is equally frequent in men and women, and African Americans are 1.5 times more likely to develop CHF than Caucasians. 44% of patients hospitalized for heart failure have diabetes mellitus. Patients with diabetes have over twice the risk of developing heart failure than patients without diabetes. Coronary artery disease accounts for 23 to 73% of heart failure, and obesity-related factors are estimated to cause 11% of heart failure cases in men and 14% in women. As you can see, MA is within the age demographic for developing CHF, and he has similar comorbidities such as diabetes mellitus, obesity, and coronary artery disease. In 2016, Ohio had the 13th highest rate of deaths from heart disease in the nation. 4.9% of adults in Ohio were living with coronary artery disease, and men had a significantly higher prevalence of heart disease than women. Black men had the highest rate of heart disease deaths in Ohio. In 2016, 73.1% of adults in Ohio with heart disease also had hypertension, and 69.4% also had high cholesterol. According to this map on the CDC website, the counties with the highest heart disease death rates were located primarily in Mississippi, Louisiana, Arkansas, Oklahoma, Texas, Kentucky, Tennessee, Indiana, Illinois, and Wisconsin. It is estimated that in the USA, nearly 6.5 million Americans over the age of 20 have heart failure. Heart failure accounts for 8.5% of all heart disease deaths in the United States. The first article in my literature review reviews the nursing management of a patient with heart failure. It discusses how the nursing care plan for heart failure patients should focus on relieving fluid overload symptoms, addressing anxiety and fatigue, promoting physical activity, improving medication adherence, minimizing treatment side effects, educating patients about dietary restrictions, guiding them on symptom self-monitoring, and emphasizing daily weight monitoring. Patients with heart failure require regular monitoring of vital signs, including oxygen saturation, heart rate, and rhythm. Daily weight monitoring is also essential. Patient education is vital to improve clinical outcomes and reduce hospital readmissions. Patients should also be educated on symptom self-monitoring, medication adherence, dietary sodium restriction, fluid restriction, and addressing risk factors like diabetes, hypertension, obesity, and substance use. Discharge planning for heart failure patients should include medication management, dietary recommendations, exercise guidance, and follow-up appointments to ensure ongoing care and improved patient outcomes. The second article is titled Effectiveness of Nurse-Led Heart Failure Self-Care Education on Health Outcomes of Heart Failure Patients. This systematic review focused on the impact of nurse-led heart failure education on patients' health outcomes and explored the modalities involved. The review concluded that nurse-led heart failure education effectively reduced readmissions, especially heart failure-specific ones. Nurses were found to be well suited for this role due to their ability to build trust with patients and their families through effective communication. This trust can enhance adherence to self-care recommendations, reduce unexpected readmissions, and tailor discharge plans to individual patient needs. Nurses also have access to necessary expertise and can collaborate with other healthcare professionals. They provided self-care support through knowledge assessment, physical exams, psychosocial assistance, and heart failure management education. These findings aligned with previous research on the positive effects of nurse-led heart failure education and similar education provided by other healthcare disciplines. The third article in my literature review emphasizes the importance of recognizing the need for palliative care early in the heart failure trajectory, involving families and caregivers in the care team and engaging in advanced care planning. The palliative care approach should focus on symptom management and adapting to changing care goals throughout the disease's progression. Some recommendations include considering palliative care at all stages of heart failure, particularly for those in advanced stages or people who are being considered for LVADs or heart transplants. Another recommendation is to take into account the needs and treatment preferences of the patients, families, and caregivers, particularly during the terminal phase. Develop tools and programs to facilitate discussions and decisions about palliative and end-of-life care. The third recommendation is to prioritize symptom control in heart failure care. Use evidence-based patient-reported outcomes for better assessment of palliative care needs. Emphasize the importance of palliative care in training programs for cardiologists and especially for nurses. The fourth article discusses the 4 classifications of heart failure and their corresponding treatments. The American College of Cardiology and the American Heart Association classify heart failure into 4 stages. Stage A is at risk, high risk for heart failure, but without structural heart disease or symptoms. Some treatments are to quit smoking, regular exercise, treatment of high blood pressure and high cholesterol, avoiding alcohol or drug use, and taking medications to control coronary artery disease, diabetes, or other conditions. Stage B is structural heart disease without signs or symptoms of heart failure. Treatments include taking an ACE inhibitor or an ARB, beta blockers for patients, especially after a heart attack, and also discussing and considering surgery options to repair the structural heart disease, such as a valve disease. Stage C is structural heart disease with signs of heart failure. Treatments are prescribing hydralazine or nitrate, especially in persistent symptoms that are seen in African American patients. Diuretics and digoxin may be prescribed. An aldosterone inhibitor may be prescribed. You also want to implement dietary sodium restriction, weight monitoring, and fluid restriction. And a pacemaker or implantable cardioverter defibrillator may be recommended. The last stage is refractory heart failure not responding to any treatments. This is when the patient will be evaluated for advanced treatment options such as heart transplant, VADs, surgeries, research therapies, continuous IV drugs, or end-of-life care. The last 2 articles in my literature review discuss the topic of pharmacological treatment. There are many medication options to manage heart failure effectively. Some key medications include beta blockers, angiotensin converting enzyme inhibitors, angiotensin receptor blockers, mineralocorticoid receptor antagonists, diuretics, sacubitril valsartan, sodium glucose cotransporter inhibitors, as well as hydralazine and ivabradine. During my head-to-toe assessment of this patient, I found the patient to have 2+ pitting edema of his lower extremities. His skin was ruddy and cold. He experienced a 25-pound weight gain prior to his admission and worsening shortness of breath. He was on 3 liters of oxygen nasal cannula, baseline oxygen saturation between 90 and 92%, and used a CPAP at night. Systolic blood pressures were soft, usually somewhere in the 90s. Ejection fraction was 10%. The patient was 6 feet 8 inches, 530 pounds. That morning that I did his assessment, his potassium was low at 3.3. The goal for this patient during my shift was to diurese and replenish electrolytes, specifically potassium. He was on a continuous Lasix drip and was getting 40 milligrams of PO potassium BID. He was on a 2-liter fluid restriction, so we had to strictly document his intake and output. At the end of the day, the outcome was okay for this patient during my shift. His urine output was excellent, over 6,000 mLs. Potassium levels increased slightly the next morning, but not enough to discontinue the potassium supplements, so he continued to get them PO. There was no change in his edema or his weight. This slide shows a copy of the nursing care algorithm that I created to care for a patient with congestive heart failure. It begins with admission and ends at either discharge planning if the patient is responding to treatment or end-of-life care if they are not responding to treatment. I created this algorithm using the evidence I collected from my literature review. This slide summarizes the key points from my presentation. A list of the references used can be found on the next slide. Thank you for listening.